So hello everybody and welcome to this session. It is my pleasure to be moderating this session on integrated care. We're going to be looking at different models that are happening real time in different countries. But before we start, I would like to thank the architects behind this session who have been doing all the work behind the scenes. So Vidya Vedham, Mishka Sira, and Jeanette Walker from the NIH are responsible for thinking about the relevance of integration of services in settings where services can be used more efficiently and benefit our population. And they took the care of looking for specific examples in different countries, which is not an easy task. So, and then they brought us all here as well. So thank you very much. Before I present our panel of experts, I just want to briefly define the conceptualization of integrated care so that we're all understanding the same thing about what we mean with integrated care. So integrated care is a fuzzy concept, so to speak, because it involves many types of different interventions. It can look in a different way in different settings. But in the end, it's always some sort of connected set of interventions that usually occur at the organizational, sometimes even the policy level. And they're all aimed at reducing fragmentation, improving coordination of care, service efficiency, and, if effective, patient experience and outcomes, which is what we are all aiming for. It includes overlapping and interrelated and at times conflicting strategies. These were findings from a review where they were trying to define the concept more clearly. But what we do find in common is that these interventions are always directed to changing the how we're doing things, how we're providing care. And they are shaped by contextual factors, and this is the reason why they can look very differently in different settings. So there's like 4 general broad types of strategies that have been used to integrate care. Among those are case management, for example, which are typically used for an individual patient where we try to identify multiple problems and provide solutions for all of them at the same point of care. Another broad type of strategy is doing multidisciplinary work, which some even say it's the basis of patient care coordination. Then there's those strategies that try to link different organizations. So, for example, integrated care pathways or partnerships between different sorts of organization. And finally, there's the whole system approaches, which is not a single strategy and is actually the most common type of integrated care, where you intervene in multiple different ways to try to improve the whole system as a whole. So in the following, in the remaining time for this session, we will be looking at different examples of how this integration of care has occurred to provide some sort of NCD control intervention. So, for example, Sam Meaty will be providing an example of how they are integrating HPV vaccination to routine care in Zambia, leveraging HIV infrastructure on site. John Kinuthia will provide us with an example of integration of mental care services to maternal health clinics in Kenya. Then we will hear Judy Kaneola speaking about how in Rwanda they are integrating NCD services to primary care rural clinics. And finally, from Simon Manga, we will see an example of how we can use mHealth technology to support integrated specialized care of pregnant women in primary care settings as well, linking the primary care physicians with specialists. So with this introduction, it is my pleasure to introduce our first speaker. Dr. Sam Meaty is a pediatrician at the Arthur Davison Children's Hospital and a researcher at the Tropical Diseases Research Center in Zambia. He has substantial clinical and program implementation experience working in both rural and urban contexts with children and adolescents with communicable and non-communicable diseases, including HIV and cancer. He is currently a principal investigator for multiple NIH grants, including the REACH study, which he will talk to us about today. The REACH study is a 5-year NIH implementation science grant for adolescent human papillomavirus vaccine integration into HIV care services. So we welcome Dr. Sam Mitty.
Thank you and good morning, everyone. I love speaking to audiences about what I do, but also because lives matter, and it all starts from discussions like this. So I'm talking to us about the importance of leveraging what we already have, HIV infrastructure, to implement cervical cancer, which in itself is a non-communicable disease, but we know that the majority of its etiology is actually a communicable infectious disease. And in so doing, it's important to understand the barriers and the facilitators that can allow integration or hinder integration in routine services, but taking a leaf from HIV care settings. And my talk is really hinged on the work that we are doing on the REACH study, which is reaching for equity in adolescent care through HPV vaccination. And by way of introduction, we know that cervical cancer is really largely a vaccine-preventable illness, but its etiology is actually caused by the human papilloma virus, which is a vaccine-preventable infection, and the burden of HPV chronic infection and ultimately cervical cancer is equally borne by females and women that are infected with HIV that have a 6-fold increase in the risk of developing cervical cancer. And the thing about it is that there is a non-intervention that can actually prevent cervical cancer if it's given at the point of before sexual debut. And in this case, the intervention that is known to work is the human papillomavirus vaccination. And we know that WHO has recommended 2 doses. Currently, evidence is going towards 1, with an additional dose for those that have got HIV. And so that's by way of introduction. And what we did in our study, which we are still doing, this is just year 2, is that in the first year we sought to understand what are the barriers and facilitators that can allow this integration. And we essentially used rapid ethnographic assessments. And we were trying to understand the context in which this service is offered and what is it that is happening on the ground to reach vulnerable populations who are most at risk and need the intervention, but also because HPV vaccination guidelines have been changing, as we are all aware. WHO has recently recommended from a 2 to 1 dose, but still with an additional dose needed for those that are living with HIV. And so we use different methods and methods of gathering this information. Now, here we look at the results that we found after looking into the context, and here you see that time and distance were significant barriers that were identified at the individual household or community level. And here we see that when it comes to young girls and adolescents that are primary targets of this intervention, different factors in the community or in their households actually affect how they receive the service or can receive the service. Information and rumors are very key factors that we need to consider, both information and misinformation, in the sense that there is limited information around HPV with a lot of conspiracy theories around there, and also misinformation that comes through about what the vaccine can do or cannot do. and also how that it is important to do outreach and reach out. Gatekeepers are key individuals that actually influence positively or negatively how information about health service integration and consumption of health services can actually be received. And so we also see that this is a very important element that came out in our study. Then parents and family really play important roles, and there have been difficult conversations that need to happen, but sometimes are not happening. In the context of HPV, we see this as a significant barrier in the sense that families and communities sometimes have got challenges having intergenerational discussions that can positively impact how we can receive services, including peer-to-peer influences. And this we saw spoke to both negative and positive influences, where children or adolescents who feel that they need to receive the service, but their caregivers don't want to give permission to receive the service, have been positively influenced by their peers to receive the service. We also then went through to look at barriers that could be at the facility or clinic level, and this spoke to guidelines and also how timing of services is done. And currently in my country, we are trying to transition to a routine way of giving, but we've predominantly been having campaign-based vaccination episodes, which speak to campaigns twice a year. Oh, great. The others really spoke to structural barriers that sometimes are difficult to have. You can have policy, you can have guidelines, but operators on the ground may not be fully conversant or fully embraced the policy in terms of implementation. And in this context, we know that we have a 3-dose, currently we have a 3-dose vaccination recommendation for adolescents living with HIV. But in terms of routine implementation, we see that everyone is implementing 2-dose vaccination, which does not discriminate whether one is living with HIV or not. But we know that according to the current recommendations, it does not offer the optimal protection. And then social barriers are important to consider as well, in the sense that HIV stigma has been an important barrier that has been highlighted in the way we do things, and just the ability of girls being seen at the HIV clinic has been a barrier. And in the context of receiving an additional dose of HPV vaccination, this is a significant consideration that needs to be taken into account. Again, I want to highlight the fact that for those that receive HPV vaccination in routine and public places, the receiving of an additional dose can actually cause stigma and an intentional disclosure about HIV or HPV, in this particular context, HIV. Then, of course, we've had behavioral barriers that speak to an intentional disclosure, but it is important to integrate non-HIV services in and learn and live from what we've done, for example, for COVID, where we've offered this in different places, including HIV care services. It's important to also do the knowledge aspect of things and improve how knowledge is disseminated to young people about the services that they receive. So really, in summary, I would like to say that it is important that we have access to recommended dosing because of this differential need, but how should it be done? And in that, we need to have equity of access as opposed to just only having equality of access, in which those that need additional doses receive it in a safe way, in a non-discriminatory way, in a way that ensures that they are protected, so that it's not just numbers that count. And it's also important that healthcare workers are capacitated to offer this integrated service, both in terms of building capacity of the system, but also being able not to exhaust them or overwhelm them to ensure that they have the services that need to matter. It is also critical that we always take into account the context in which these services are offered. And when we talk of integration, context matters. And the people that we intend this service vis-a-vis adolescents living with HIV or those that do not live with HIV need to have their views considered. So context matters, and let's hear their voices as we offer integrated health services. Like they say, there is nothing for us without us. And so as we integrate health services, there is nothing for the adolescent girls without hearing their voices. Thank you.
Thank you very much, Sam. We will now go to our next speaker. So it is my pleasure to introduce Dr. John Kinuthia. John Kinuthia is an honorary lecturer at the Department of Obstetrics and Gynecology in Nairobi University. He's also director of the Integrating Prevention and Treatment of Non-Communicable Diseases and HIV Care through research training in Kenya. He has substantial experience conducting biomedical and social behavioral research in Kenya, providing HIV care, and mentoring and training different cadres of healthcare and research personnel. He's one of the principal investigators of a study evaluating effectiveness and implementation outcomes of the Integrated Perinatal Mental Health Program in Kenya, of which he will talk with us about today. So, welcome.
Yeah, thank you, Carla, and good morning, everyone. I want to start by thanking the conference organizers for the opportunity to present about our program. Perinatal mood and anxiety disorders refer to depression and anxiety during pregnancy and up to 1 year postpartum. This is a condition that is common, affecting 10 to 20% of perinatal women. The burden is higher in low and middle income countries and also among women who are living with HIV. In addition to causing significant disability among perinatal women, this condition is associated with increased risk to the infants, with increased risk of preterm births, low birth weight, pregnancy loss, and stillbirths. To reduce these adverse outcomes requires identification and treatment of perinatal women with anxiety and depression. However, mental health services are not standardized in antenatal and postnatal clinics in many low and middle-income countries, including Kenya. To address this gap, there are increasing calls for integration of mental health services in routine care settings. Kenya has an action plan which is promoting integration of these mental health services in routine settings. Maternal and child health and prevention of mother-to-child transmission clinics are actually an excellent platform for integrating mental health screening. They are widely attended, and if you can see the data from Kenya, we can see 95% of women make at least one antenatal care visit. They are also robust and really highly effective programs and will definitely contribute towards destigmatizing mental health. Therefore, integrating mental health in these clinics offers opportunistic access point for anxiety and depression screening and an opportunity to expand access to mental health services. Women in low and middle income countries have limited access to mental health services with low rates of screening and treatment. 3 in 4 women in need of mental health services do not receive them. And they would need to travel long distances, as Sam has pointed out some of those barriers with HPV similar in mental health. And also, there would be extended wait times for them to see specialists. Additionally, low middle-income countries have very low numbers of mental health specialists. For example, in Kenya, we can see we have one mental health specialist for almost 500,000 population. And this is compounded by limited healthcare workforce, which calls for tax shifting as a strategy to be able to provide services. Our program, the Integrated Perinatal Mental Health Services, seeks to address this critical gap in access to mental health services by employing 3 evidence-based interventions implemented in maternal and child health clinics to ensure access. These are a universal mental health screening, problem management plus, which would be provided by lay counselors and telepsychiatry. Our program is, we are going to use a participatory design to optimize IPMH and to develop implementation strategies. So we are going to have a stakeholder, Sam was talking about context matters. So we are going to engage policymakers, healthcare workers, and also women living with HIV and those living without HIV who are coming for antenatal care, so that we can identify perceived barriers, anticipate facilitators, and also come up with an integrated program which can be effectively be delivered within the PMTCT and MCH environment. We'll also evaluate effect of IPMH and implementation strategies on health outcomes, looking at anxiety, depression, HIV care, pregnancy outcomes, and also importantly, look at the effect of IPMH and implementation strategies on service delivery and implementation outcomes, looking at penetration, efficiency, and fidelity, so that we can be able to develop a ready-to-scale implementation strategy which can ideally be adapted in many other low-middle-income countries. So we'll conduct a cluster randomized clinical trial in 20 facilities in Western Kenya. Western Kenya is the region in Kenya where we have the highest HIV prevalence. You can see here. Yes. The women in control group, we are going to enhance the care by ensuring that there is screening happening for all of them, and also creating referral charts to ensure that when they need to be referred, they can be sent for appropriate care. For the intervention group, we'll employ the lay counselors to provide counseling with an opportunity to scale up service as needed, all the way to a point of where we can have a telepsychiatry. So we'll use a stepped care model with the multidisciplinary team, with the peer-delivered interventions, that is screening and also problem management plus, intensification of care as needed, and women who require a specialized care because they are not responding to problem management plus, or because of the severity of the symptoms, will be seen by a psychiatry. We will employ, our lay counselors will be mentor mothers and also HIV testing counselors. And mentor mothers, as we all know, have been very instrumental in PMTCT programs, and they will be trained to provide depression and anxiety screening using PHQ-2 and GAD-2, and provision of problem management plus and the supervision of nurses. The screening will use the two questions of PHQ-2 and the two questions of GAD-2, and women who score more than 3 will be referred to the nurses for evaluation through PHQ-9 and GAD-7. The problem management plus is an effective intervention in treatment of depression, anxiety, and stress. It's a low-intensity psychological intervention which has been endorsed by WHO, and it consists of 5 weekly sessions that cover managing stress, managing problems, increasing activity, and strengthening social support. These counseling sessions will be task shifted to mentor mothers and HIV testing providers due to the reasons I gave previously. The low number of mental health specialists and also the overstretched healthcare workforce. For women who with severe symptoms or who do not respond to problem management plus will be reviewed by a psychiatrist remotely. So we'll be able to organize for the women to be supported by the facility nurse and connected to a psychiatrist remotely so that they can provide consultation and treatment will be provided and relayed virtually. I want to thank National Institute of Mental Health for supporting our study participants, study staff, the Siaya County, Homa Bay County and Kisumu County governments, as well as the large study team. Thank you very much.
Thank you, John. We will now move on to our next speaker. It is my pleasure to introduce Dr. Judy Kanyola. Judy Kanyola is chair of the University of Global Health Equity Center for Nursing and Midwifery based in Kigali, Rwanda. She is a registered community health nurse and midwife, and a recognized nursing leader in Africa with over 25 years of experience in clinical nursing and education programs. Judy is currently the Africa representative for Nursing Now, the global campaign to raise the status and profile of nurses and midwives worldwide, and the 2019 recipient of the Association of Nurses in AIDS Care Global HIV Award. She will share with us her experience in the integration of NCD care services to primary care rural clinics in Rwanda. Welcome, Judy Kanyola, please.
Thank you very much for that warm introduction. I'm going to talk about nurses, and I'm going to talk about primary care and what we're doing to integrate services through that. As we know, we have a fragmented provider-centered model of care that really, as I think, and every time I come to conferences like this, we always talk about it, that our health systems are unresponsive, they are uncoordinated, they are not in line really with the population and patient needs, and finally, they are inequitable. So primary care, therefore, achieves integration by bringing a team of health and social professionals in close contact to the patients and the populations that they serve. And so when we are looking at integration, first of all, the primary care is doing one, identifying the health and well-being needs, which is present and past. So when you come to the health center or to the district hospital, for example, in Kenya or in Rwanda, where I live and work, you're bringing your presenting need. And when you see the health provider, they're going to take a health history, they're going to talk about your past, they're going to say what happened yesterday or what happened last year. And that, therefore, brings the past and the present. But then again, primary care moves beyond that and really is tackling what are the main causes and risks of ill health that we are seeing now. I think the next session across is talking about climate change. That's become a big issue. So what are the challenges we are facing presently? Many of us who live in Eastern Africa have a lot of conflict in some of the countries that we border, that we neighbor. I think we are all aware of the conflicts that are happening around the world currently. So again, primary care is tackling the main causes and risks of ill health. So really not looking at people as one person, as episodic, as fragmented, but as a part of the whole. And then, of course, last but not least, we have to look into the future. What are some of the emerging issues that we are seeing? I think there's a session after this afternoon that's looking at AI, and all of us are all grappling with this animal called AI. How are we going to deal with that? There's a lot of things I was reading, and I was shocked because I've been jumping up and down and saying, yeah, they'll never replace nurses. Only shock on me to realize that there's something called HNR, a humanoid nurse robot. I was like, oh my God. So let's talk about Rwanda's nurse-led model. As we all know, this is very straightforward to many of us. Non-communicable disease care in Africa, especially sub-Saharan Africa, remains low. Our NCD services are largely restricted. I think Dr. Kinuthia, who's working in mental health, will tell you, to urban, central, and specialized hospitals, mainly in the urban, peri-urban. So when you go to the rural areas, you're not going to get specialized services. And as we know, NCDs require a kind of specialization that's often not present at the rural area. When you have diabetes, and then you have a comorbidity, maybe like HIV, or you get malaria, and so all of them, 2 or 3 different pathologies happening in your body at the same time, require a level of specialization that's not often found in the rural areas. And NCDs, by the nature of just that disease, often have that. So from 2015 to 2017, the Rwanda Ministry of Health implemented an outpatient decentralization strategy to rural first-level hospitals, and here we were focusing on chronic NCDs, type 1 diabetes, heart failure, and severe hypertension. As we know, the severe NCDs have a high level of morbidity, disability, and mortality. So 2006-2008, we collaborated with NGOs, partners in health, in Nshuti mu Buzima, as it's called in Rwanda, to establish NCD outpatient teams in 3 rural district hospitals. We then trained 2 nurses at each of the country's 42 level 1 district hospitals. And so this work was nurse-led, integrated outpatient NCD clinics focused on the severe NCDs that I mentioned. Treatment and follow-up of type 1 and 2 diabetes mellitus, heart failure, hypertension, severe chronic respiratory disease into a single shared space. So they were all coming into this space, which had, staff, space, and equipment, and this is how we were treating these patients. And each NCD clinic was led by 2 NCD-trained nurses, and these nurses then were supervised by a generalist physician. And then also we developed some simplified diagnostic and management protocols. Medical specialists trained these nurses over 3 months, and they were trained on echocardiographic diagnosis, HbA1c testing, insulin titration, diuretic management. And then the NCD nurses then trained nurses in the primary care facilities. In Rwanda, these are the health centers and the district hospitals, in things like non-insulin dependent type 2 diabetes, non-severe hypertension and asthma. And so enabling a progressive decentralization and integration of chronic care for common NCDs into the clinics. This integration also included, and I was happy to hear Dr. Kinuthia talk about mental health, HIV, and TB. So the results, by 2017, all NCD clinics were staffed by at least 1 NCD-trained nurse. The most common diagnosis that was seen at that time, 70%, was hypertension, 19% type 2 diabetes, and chronic respiratory disease at 5%. There was quite a lot of type 1 diabetes, 4%, and heart failure at 2%. Also, 70% of the national medicines for these diseases were available at these health facilities. The exception was warfarin and beta blockers for heart failure. And then when we looked at this again, 70% of the nurses adhered to the clinical protocols, meaning that they were managing the patients fairly well. So this is just an example of some of the results, the lab testing, as you can see, at 2015 and 2017, and how it progressed, the equipment that was there. So the district hospitals were then equipped with ECG equipment, ultrasound, cardiac probes, and this also enabled progressive good management of these NCDs in the rural areas. And these again are just the results. The drugs that were there, we were having metformin, insulin, lente insulin, regular insulin, nifedipine for the hypertension, atenolol. These are just the essential drugs that are in our Rwanda, formularies for things like asthma. We had salbutamol inhalers, captopril, furosemide. So all of these were, increasingly made available at the district hospitals in these rural areas. And then again, this is just showing how the nurses were adhering to the fidelity of the management of these diseases, making sure they're doing the right lab tests and giving the right treatment. The penetration was quite good, as you can see. Majority of the patients that we saw had hypertension, followed by type 2 diabetes, type 1 diabetes, and then heart failure. So the challenges, of course, we can't fail to have challenges. There was high staff turnover. We needed to do regular training of this NCD. So every time you train, the nurse goes, we have to train again. The support for the expertise consultation as well, because as you all know, the specialized doctors, specialists, internal medicine, physicians are not readily available. Of course, we lacked equipment, lab tests, and ultrasound, and like I mentioned before, the essential first-line drugs at those district hospitals. However, Rwanda has been able, despite these challenges, to demonstrate improved population health through primary care, and particularly the use of nurses, which for me is really great, because through this then you access integrated chronic care services, especially for severe NCDs. The challenges we face in the rural areas that an NCD is something you live with every day. So you need your medicine, you need to be followed up, and if this is not done, it leads to a lot of suffering, pain and suffering and death, and many of our people live in the rural area. So, for us, imagining that these people must come to Kigali or to the urban and peri-urban areas for treatment is really, it's just like, what are we doing when majority of them live in the rural areas? So we must then be able to take care of them where they are. So I think for me, that's what's like the most important thing to remember. And of course, the quality of care, it may not be 100%, but we're getting there. The continuum of care, of course. So you're looking after, many times you see somebody with hypertension. This is a mother or a father, they have a child. So it's not looking at somebody in isolation and they're going home. So expecting somebody to come to see a doctor, maybe the day they come, the doctor is not available. Where do they stay? In the urban area. Where do they stay? If the doctor comes, they sit in the line and they don't see the doctor. So what's that quality really that we are giving? And of course, cost effective, because then you're preventing the progression of this disease in the body, eventual morbidity, mortality, which as we all know is more expensive. My time is up. Nurses, because of the nature and ethos of their profession, are a key pillar in successful integration of health services, especially for NCDs. I would like to acknowledge and gratitude the PIH IMB team, the Rwanda Ministry of Health, and NCD nurses across all district hospitals in Rwanda, and of course all of you for listening to me.
Thank you, Judy. We will now move on to our last speaker. It is my pleasure to introduce Dr. Simon Manga. He is a reproductive health specialist serving the Women's Health Program of the Cameroon Baptist Convention Health Services as a clinical consultant and research scientist. And he also serves as Deputy Director of the clinical services. He has several years of clinical experience and research, especially in cervical cancer screening, colposcopy, and HPV vaccination, but also other gynecology and obstetrics interventions. Today, he will share with us his experience with the implementation of an mHealth supported intervention to integrate specialized care of pregnant women to primary care services. Welcome, Dr. Manga.
Thank you very much, and good morning to everyone. I'm honored to be presenting on behalf of the Cameroon Health Initiative at the University of Alabama at Birmingham team. The goal of the Cameroon Health Initiative at UAB is to promote women's health in Cameroon. And our partners include the Cameroon Baptist Convention Health Services, where I work, the University of Boya, and the Ministry of Public Health. This initiative has been able to secure a series of funding for clinical projects, pilot projects, training. But today I'll be talking exclusively on the MMIST project. Reducing maternal and perinatal death is a global priority. So timely and quality pregnancy care by skilled providers is crucial. The UAB MIST, that is the Medical Information Service via telephone, which has been running for over 50 years, seems a prototype intervention that can promote quality care in low and middle income countries. Healthcare workers in Alabama access UAB specialists through the MIST for consultation and to receive guidance. Aim 1 in this project was to adapt and develop a 24/7 mHealth support system for primary providers who provide health care to pregnant women. Aim 2 was to test the MMIST feasibility and acceptability in health district in the northwest region of Cameroon. And Aim 3, which is currently ongoing, is to implement and evaluate MMIST in reducing maternal and perinatal death and serious maternal and neonatal morbidities in the northwest region. For M1, we conducted 46 in-depth interviews and 3 focus groups among 64 participants, including pregnant women, care providers, mobile service providers, Ministry of Health officials, and hospital administrators. For the teams that emerged for M1 were as follows: many negative experiences by healthcare workers and patients, frequent emergencies, as you can see there, for those for the mother and those for the infants. We also have barriers to care, especially shortages of personnel and equipment. We have low antenatal care utilization, and also external factors such as the current conflict which is going on in Cameroon. The MMIST is centrally located in a large CBCHS hospital in Cameroon, and it has a 24/7 coverage where peripheral providers call to get help, and dedicated nurse midwives working in labor and delivery serve as the first-line respondents. And we also have experts, physicians, who can be put on a backup to facilitate the discussion. So the MMIST call flow is like this. The peripheral provider calls in, the first-line provider will pick the call and answer. I will provide guidance. And if there is a need to include an expert physician, then that expert physician is going to be connected to the call. This diagram is a representation of the MMIST process. So as you can see here, 2 peripheral providers can call at the same time in a landline in the labor and delivery ward in the CBCHS hospital. And if necessary, 2 expert consultants, an obstetrician or a pediatrician, could be added to that call to form a conference in that case management. Every call that is received is recorded in this evaluation form. All MMIST calls must be related to maternal or newborn cases, especially those related to emergencies. As you can see here, the common causes of calls. You can see the common causes of calls for the mother and those for the babies. So the peripheral provider calls into the MMIST system through the landline and then take part in a conference call if the call is forwarded to an expert physician. And then that peripheral provider will be responsible to execute the instructions from or the recommendations from the call. For effective MIS case presentation, we develop a format for case presentation by the peripheral providers. So this is the structure. So each time a peripheral provider is calling, this is how the call is supposed to be organized. You can see in this bar chart, during the pilot phase of the project, the call started timidly and they increased by month over time. And here you can see the outcomes of the different calls. During the pilot, we received 94 calls. You can see that 37 cases were treated locally, 21 were transferred. At the beginning of the project, the involvement of the expert physician was a little bit timid, but over time, the primary responders learned to include the expert physicians in the call. So far we have been able to adapt the MIST, and we have trained and supervised MIST personnel where 100% understood the purpose of MIST, 98% agreed that MIST will be helpful in providing care to patients, 90% are satisfied with the MIST training. And now we have developed the final version of MIST, which is being tested in an R33 phase. We have been able to include 12 of the 16 districts in the MIST project. So 4 districts are left, which will be added in the next 6 months. We have been able to collect administrative data. We have up to 20 first-line respondents and 16 expert physicians, so backup. So here you can see the landline for the call, which the numbers which are given to the peripheral providers to call in. And here is a map of Cameroon showing the various districts for which the project has been implemented. Finally, we want to appreciate Dr. Alan Tita, a Cameroon American obstetrician gynecologist, who is one of the PI for this project, and he's based in the University of Alabama at Birmingham. And this project was sponsored by the NICHD. Thank you.
Well, thank you to all of our panelists for being right on time. And so now we have a lot of time for discussion. So please, anyone who has questions, line up behind the microphones. We will take turns. We would just kindly like to ask you to keep your self-presentation brief. Avoid providing comments if possible, and just give us one question each, please. So we will start over here with, yeah, go ahead.
Hi there. My name is Dr. Rajiv Chaudhary. I work in the Department of Global Health in Florida International University. So my question is to Judy, if I may. So it's a very impressive work that you're doing in terms of leveraging and mobilizing the nursing workforce in Rwanda for NCD care. I was just wondering a couple of things. So at the primary care level, so this is principally, if I understood it correctly, a facility-based approach still, right? So the nurses are helping the patients, but so are these nurses providing dedicated care for NCDs, or they have to share the workload for other things like MCH care, for instance? So that's my first question. And secondly, also, have you considered any community to facility approach as well by working with such as community health workers to further, increasing the access and perhaps monitoring as well? Thank you.
Hello. It's on. Thank you so much for that great question. Yes, the nurses are dedicated, so they're NCD nurses, and so their work is specifically to manage the NCD. So they're not doing, in a sense, any other thing, but just running the NCD clinics. So the patients who come just go to the with NCDs, see those nurses and follow, and that's what happens there. You are very right, and I think that will be the next level of this work, is to move into the community. And one of the things we are grappling with on how best to do it, as you say, perhaps using the community health workers model to manage the patients with NCDs within the community. The challenge we face, of course, is the severe health workforce shortage, and then the level of training that would be required to manage well the NCDs. So I agree with you completely that that should be the next thing that we should do. Thank you for the question.
So I was very fast on passing on the mic, and I forgot to make some comments to highlight the commonalities of all of your projects, which I think are very interesting. So one of them is that these are different ways of increasing access. All of you, no? Increasing access to a service that would not otherwise be there for these patients. We had an example from Sam to provide access to vaccines, access to mental care, access to NCD care in rural clinics where no specialists are available, right? And then a way to support primary care physicians in both of your cases to connect them with specialized care, Simon and John. So I think this is super interesting and useful for our low and middle income settings where we don't have some services. Then the other commonality is the great relevance of context, which I loved how Sam put it. Nothing for us without us, which still so very often happens in low and middle income settings, no? Where someone from abroad comes and tries to tell us with good intentions, like what we should be doing, but then we miss the point of taking into account the local vision. Then I would also like to highlight the task shifting, which appears to be key in many of your projects, right? And finally, the support of primary care. We sort of drop everything on primary care, but then they cannot really do everything. So any thoughts on these sort of topics are most welcome. How you see your projects moving forward for sustainability, considering that we want access to be improved like continuously, right? Not beyond the research projects and beyond the pilot projects. You want to start, Sam? Or whoever wants to start. I didn't mean to call on you. Your thoughts on sustainability. Mm-hmm.
Yeah. Thank you very much for that. I think it's important to have sustainability from the onset as we think about integration, and fragmentation of health services is one of those things that hinders integration. So as we move into next phases of whatever it is that we do, we need to remember that it's the same patient that tends to seek services in multiple places, and so fragmented services may hinder. But on the flip side of things, it's also important to leverage what has worked well. What is it that has worked well, for example, for infectious diseases, that in the context of HPV and HIV or cervical cancer, we are saying, can it ride on an already firm, solid infrastructure that has been built over time from HIV, whether it's tracking of patients or keeping track of services, or just ensuring less fragmentation and integrating services so that the patient is able to receive multiple services in one service point or one service visit. Yeah.
Just to follow up, I think when these services are anchored within government programs and action plans. Like in our case, the mental health action plan is already envisioning using lay providers as a way to extend these services. Then working with established programs, like the PMTCT program has been very effective in many countries. The investment by PEPFAR has really built a very strong program. Again, the MCH system is also a very strong program. So working within those programs and having them being embedded within the government plans ensures that these are services that will go beyond the funding for the research or for the program.
For me, I think the sustainability also comes in very well when you are taking into consideration the whole system rather than, sometimes often we say, oh, we are managing HIV, but HIV has other added components. So for example, with primary care, we were looking at how is the drug system working to make sure that you have a disease, but if there are no drugs, if there's no equipment to diagnose. So it's sort of looking at it from a whole system approach, and why primary care, for example, is saying, can we take this whole system to the lower level as opposed to the urban and maybe tertiary referral higher levels, which it was there before. So slowly but surely now building that infrastructure. It's not done overnight, but at least we are now saying we have the laboratory, we have the drugs, we surely certainly can improve. We have the workforce, in this case it's the nurses and the midwives, and so that system now is coming down to that level, and I think that's also another way of ensuring sustainability, because now it becomes embedded in the national system. It's not a standalone program funded maybe externally or dependent on a short timeline, 5-year project or donor funds or things like that. So while it will have its challenges, of course, being national, maybe there's stockouts and so on and so forth, lack of staff and so on, space and all that, but at least you are sure that you are now going in the right direction. Thank you.
Okay, thank you. For sustainability in my project, the project is there to empower the peripheral clinical workers, because each time they do a case presentation and I get this feedback from experts, it's like a continuous capacity building. And so at some point, things that they were not able to handle on their own, you find that they'll be able to handle, they'll have some challenges cases and they'll not call, they'll be able to, they'll just know what to do because of that continuous education, continuous case presentation. Thank you.
Let's keep with the questions. In the front microphone, please. Yeah. Mm-hmm.
Hi, Jonathan Cohen from the University of Southern California. Thank you all. I'm wondering if any of you can go into a little bit more detail about how you worked with patients and communities to design your interventions. What methods did you use? Was it focus groups or interviews? What did you ask people? Thanks.
Thank you very much. I can share some of our experience now that we're essentially coming from a point where we've engaged with key stakeholders. So we've used rapid ethnographic assessment as a way of engaging with stakeholders, and the tools that we've used included, or the methods we've used included focus group discussions. We've convened at least 2 stakeholder meetings where we had representation both from the interest groups of or representatives of the adolescents themselves, people that provide the vaccine, people that run programs, and also other stakeholders that are important in the community, like the traditional leadership in our context. So all those were some of the things that we did to literally ensure that we understand the ways and who does and what matters to the system, as well as to the beneficiaries, as well as the providers. Yeah, so stakeholder engagement is key in this co-design process of interventions.
Thank you for the question. For our program, we are in the preparation phase, but we do plan to have focus group discussions and key in-depth interviews with the different stakeholders, that's the policymakers, the healthcare providers, and also the women who are living with HIV, and also those who are not living with HIV. And basically, what we'll be trying to see is we have this intervention that we are planning, and we want to get their input in terms of how they think it works best to serve them, if it's for the women with HIV, how it can be implemented when we are talking to the healthcare providers, what do we need to do in terms of patient flow to ensure successful implementation, and also working with the policymakers to see eventually how would this be taken up and how can it be scaled. So we'll have workshops after we do our focus group discussion, where we'll also have all those stakeholders represented and agree on the implementation framework and the implementation strategy, what we are going to do. Besides that, we are going to use a participatory design approach. We are also going to get 12 representatives from these groups to be part of our team, and we'll work with them as we refine and optimize our intervention. Thank you.
Yeah, I think as I even presented in my work, our M1 was exclusively on focus group and in-depth interviews. So it's just the same approach. Thank you.
The first person in the microphone of the back, please.
Okay, thank you so much. I'm called Arthur from Medical College of Wisconsin. I'm a PhD student, and my question goes to the person from Rwanda. She answered that the next plan is to engage community health workers. My question is about to what extent did they go beyond the medical model to do the social model so that they are able to look at social determinants of health. For example, to do patient-centered care, where, for example, like the non-issue independent type 2 diabetes, to what extent were you able to integrate self-care for patients so that they have that empowerment beyond the medical treatment they receive at the centers to be able to sustain, for example, the self-care behaviors that are recommended by the diabetes educators. Thank you so much.
Thank you. Very good question. I think we are starting from the beginning, so from zero to something. So I completely concur the medical model. I personally also don't like it, but it's what we have now. So we are saying we had zero, now we have 1 or 2, and then for sure we'll move into what you're saying. But at least to say that some of the protocols we developed, which is in the treatment and the algorithms that we are using with the nurses, do include a lot of what you're saying. And also in and of itself, the nursing profession is very, can I say, holistic, or tries to be holistic in its approach. So we have a lot of health promotion and disease prevention embedded in there, even though we still have the medical model where the patients are coming to us, where we are still kind of following that type of way, but at least within the clinics where the nurses are looking after these patients, we are doing a lot of that self-management, nutrition, and so on. So some of the things we have now added since that time is things like nutrition and bringing in the nutrition element and having this expert in that field come in, where we are looking at some of the challenges why patients don't adhere to drugs. We find that men often are the culprits in this area, and supporting them in ways to make sure they take their medicine as needed. And also things around stigma. So things like hypertension still carry a bit of stigma when people don't want to disclose. When we unearth other illnesses that these patients come in even when they have NCDs, things like even using the inhalers for people with respiratory issues. All of that are done within the clinic, and I do agree. And those are the things now, slowly by slowly, we are moving into doing to ensure that we bring in the community, work in the community, and recognize the social determinants, as you say. Thank you.
So the first person on the microphone on the left, please.
Yeah, thank you so much. Very much enjoyed these Africa-based, and Africa-led, very innovative interventions. So thank you all. I'm Christine Garuya. I'm an associate professor in the Department of Emergency Medicine and Global Health Research Director at Stanford. So quick comment on 10 seconds, only because you mentioned it. As we focus on primary care, and then a question. As we focus on primary care, not to also forget emergency medicine, which I can assure you, having working on NCDs for 10 years in Africa, in Kenya, thank you, Prof, for all your great work, Kinuthia, that it's a very highly vulnerable population, marginalized population, and as we get to PHC and UHC, let's not forget the emergency department. My question, so Dr. Kunyola, again, really excellent work, so and so much of what Rhonda has done for NCDs, but for methodology-wise, how did you measure ultrasound quality? How did you do QI for your ultrasound education, just for maintenance? Not letting perfect be the enemy of good, but how have you been able to do ultrasound QI? Because nurse training for ultrasound is a great idea. And then my second question is similar for QI on adherence to guidelines. How are you measuring that? You said 70%, but I'm just curious, again, not letting perfect be the enemy of good. Or is it self-report, or how are you objectively assessing those two?
Thank you very much, Dr. Ngaruya. Nice to see you again. Yes, what we did is that we followed up after. So we did something in 2015. This started some years back in 2006 to 2008. And then in 2010, Rwanda Ministry of Health had something they called a target 80 by 40 by 20, which is 80% of the population under 40 by 2020, because often we are seeing a lot of these NCDs, particularly hypertension in the younger population, are getting treatment. So based on that, the team that was training the nurses together with the Rwanda Ministry of Health, we developed certain protocols and certain things that we then followed up to supervise and worked against. So we had like baseline information, then would go back to say how much of whatever parameters we had put are you fidelity, adhering to. I don't want to get into much of the details, but that's sort of what we did. So at 2015, we did something, and at 2017, we did something. And that's where we were getting some of the challenges, like, for example, staff turnover. So you find that when you go, the nurse you saw, Judy, in 2015, when you go back after 2 years to see how is that going, you're told Judy left, and this new nurse who came did not know the protocol that we are using, and so we sort of had to start again. So those were some of the challenges. But we did have baseline data within which we followed up. Regarding ultrasound, yes, we did train the nurses in ultrasound, challenge being that only after some time is when we did get the ultrasound machines, for example, in the district hospitals. We haven't even got them yet. Now we are implementing what we are calling a medicalized, which again, I don't 100% agree with, but I think it's better than nothing. We're calling them medicalized health centers. So health centers in Rwanda are very much outpatient, focused very much on really simplistic management of disease, but we are making them medicalized, where now we are bringing in ability to care for more of the complicated or complex diseases. So now we are adding a laboratory, which was not there before. We are adding the ultrasound, we are adding surgery, we are adding a few other things which were not there. So these medicalized health centers, for example, have come out of some of that. So I hope I answered you, and now that goes with the training, which we are doing, for example, for nurses with ultrasound and so on. Thank you.
The microphone in the front, please.
Yes, thank you for the presentation. I am Patricia Efe Aziki. We work with Partners in Health based in Sierra Leone. My question goes to the speaker from Cameroon. I do not know if you have a plan to expound the phone calls to the adolescents. in case they have any issue that they want to call either for advice or for them to come to the facility. And secondly, we suggest that apart from calls for emergencies, what of people calling in either for advice or for health education? Then my question goes to the second question goes to the speaker from Kenya. What is the place of preconception care in early detection of mental health problems among HIV pregnant mothers? And secondly, I want to know why you excluded postpartum blues that comes earlier before postpartum depression. Thank you.
Okay, thank you. Yes, we have to go one step at a time. So for now, we are looking at pregnancy. And because our maternal mortality rates are high, so our first step is like, how can we bring down this high maternal mortality rates? So the inclusion of, or extending the services to include adolescents and others, probably that will be a thing for the future when our maternal mortality rates must have gone down. Thank you.
Yeah, thank you for the question. And I totally agree that it's important to prepare for pregnancy. So preconception care is actually very important, and it's an area that we should invest more. However, currently we have very little in terms of infrastructure for preconception care. It's a good idea which is still taking time to build up. So in our program, when we are thinking, we thought of where we are likely to have the greatest impact, and that's why we chose to work with the MCH and within the PMTCT program. But in terms of can this idea be carried so that it becomes part of the preparation during pregnancy, I agree that as we set up these clinics, then that is actually important, and definitely it's better to prevent a lot of some of these conditions before pregnancy than during pregnancy. The same way we want to control diabetes, the same way we want to have the woman being virally suppressed before pregnancy, the same way we don't have to be anemic, is the same way we would want to address the mental health issues. However, it's also important to keep in mind that pregnancy, because of the changes, also contributes to some of those problems. So they cannot necessarily all be completely addressed beforehand. Thank you.
The microphone on the back, please.
Hi, this is a question for Judy. My name is Lindsay. I'm from the Center for Global Health at Mass General Hospital. This kind of piggybacks on the last question about ultrasound, but to expand it a little bit more. I thought a lot about scope of practice during your discussion and how, like US-based nurses, if we were to implement ultrasound, especially cardiac ultrasound in our practices, we would be starting a revolution, and I think it's a revolution we should have started yesterday, but in terms of convincing the national system in places, how do you suggest convincing national systems to expand the scope of practice for nursing and include competencies like ultrasound and convince them that we can perform high quality in these competencies?
Yes, you're very right. I think it's an ongoing thing that we do. One of the things that helps us is simply necessity is the mother of invention. So the high mortality and the increasing burden of NCDs that's known globally, and even in Rwanda we can see, has helped our cause and allowed for scope of practice. But one of the things that is an insistence is that you must undergo training. That training has to be vetted and approved, and we certify that. So it's not just anybody going willy-nilly and doing that. And like I mentioned, some of the challenges we have faced is actually being able to keep these NCD nurses. And because when they go, we can't now just bring any nurse to then run the NCD clinic. But so our certification, can I say, is not like a broad, open scope of practice, but that the ministry has allowed. And why, again, working with your ministry, speaking with them, helping them to understand has been our partner, has greatly assisted. In the rural areas, it's highly unlikely, particularly when you go down to the health post, to find even a generalist physician there working. So they are aware of that, and that is why they have allowed, for example, these NCD nurses. One of the things that I'm doing perhaps at the Center for Nursing at UGH is beginning to see if we can develop an NCD nurse who's actually then qualified at a higher level, perhaps at even a postgraduate or master's level, who will then be commensurate to avoid this high turnover, kept there and working there to make sure that all these things you're saying happen. But engagement with all the stakeholders, political will is a big issue. You need to really get your Minister of Health or your politician to understand. One good thing is that there are no doctors, so that has really helped. We don't even have to argue much with the minister when he knows very well himself is a doctor, and we are like, Daktari, are you in that village? And he knows very well there's no one there. Actually, when we were doing the statistics, we found that there were only 1,300 doctors in Rwanda. So in a population of 13 million, I don't know what that mathematics is, but I think it can show you the stark need that is there. So yeah, thank you.
Thank you. On the left here, yeah.
Hi, thank you so much for this really stimulating presentation. And I am Laura Wexler. I'm a cardiologist at the University of Cincinnati, and I am participating in the Cincinnati Rwanda Initiative, which is an effort to bring more cardiovascular training to the University of Rwanda. And also I participate in the recently established Cardiology Fellowship Training Program. We now have 6 Rwandan fellows training in cardiology. My question is, I am an absolute true believer in primary care and very excited about this primary care model for the management of hypertension, heart failure, diabetes. My question is, that line on one of your slides, that one of the challenges is obtaining medical specialty help or consultation. So I want to ask you, what is your wish list for that? What would the best, most effective and efficient subspecialty help consultation look like to you? What is your ideal model of how cardiologists could back up your program?
If they can be available when we need them. So I think I like either by a telephone because it's raining and I'm the nurse, and then the patient has come and their BP is not going down. So how do I get you Prof. Wexler from Wexler? So if we can find a way when we need them, not when they feel like coming or when they have a minute on their calendar, that would be great. So, and then not just like one-off, but then a system. So that if I'm sitting there as a nurse and I'm seeing this intractable, BP that's not going down or whatever it is, then I can talk to the specialist in a way that there's a call system or something. That's number one, for the individual patients that we see. And then number two, also to help us not look at always the sickness, but the prevention. And one of the things we need to do is find out what's causing all of this hypertension at the younger levels. So there's more than just, the individual with that high blood pressure or with the diabetes and having that. So that system approach. One of the things we see as nurses, for example, are the social issues. So a man who comes in who has diabetes has other, I want to say, sexual issues related to that. Nobody wants to talk about it, but the man is there looking at him, I'm looking at him, and we don't know what to do. The specialists can help us. Are there drugs for that? Are there things that need to be done? The social issues. This is somebody, for example, who is young, is the breadwinner, has this diabetes is often sometimes even hiding. He doesn't want to be known because he fears he might either lose the job or he'll not be able to work, or whatever it is related to all of that. So can there be a system where we can be helped as nurses, skilled, other issues brought into the care, not just the heart rhythm or the pure pathophysiology, but the whole system issue, and working with us to then embed it into the disease prevention and health promotion model. So we are not always waiting for that BP to reach 200 and starting to give captopril at that level, but really saying, how do we make sure that this is managed before it gets to that critical level? And then also, of course, like you say, some of the critical issues that are there, we may need the specialists to come there rather than making patients go to King Faisal, for example, or to Rwanda Military Hospital for surgery or other management. So maybe bringing the services closer as well, the expertise and the knowledge closer to the ground would be very, very useful. And creating a system where we can consult in a easy way, get the answer, and then also get what we need. Because if I consult you and you say, give the patient this, but I don't have it, then again, it's still not useful. So it's a system answer, if I may say, and I hope I answered you. Thank you.
Yes, and I will just say that I am optimistic because, number one, I think there will soon be many Rwandan cardiologists who understand the country and can provide these services. Number two, many of the kind of technology testing that we do can be interpreted virtually. My daughter is a primary care doctor and regularly texts me ECGs for interpretation in the middle of the night, which I'm always happy to do. And I think that, thirdly, I think it is critically important, I totally agree with you, to keep much of this care, particularly the prevention and the early care, to keep it at home for the people in their neighborhood, in their village, with primary care nurses. So I'm very optimistic that this can be achieved.
Thank you for your work as well in Rwanda.
Well, thank you all for an amazing session. We're getting to, sorry? Where is it? Oh, she was not there anymore. I'm sorry.
Hi.
Go ahead.
It's okay. I'm Bernice. I'm a gynecologist in Pennsylvania, but before that, I trained and lived all my life in Peru. I'm Peruvian. So I just have a question to Judy, just regarding more like operational. Do you have a specific or a different incentive to the nurses for them? Because even though for a lot of us, knowledge and knowing more is just an incentive by itself, our reality is that you need to take time off from your second or third job as a healthcare worker in our countries to be able to do that. And then how do the doctors supervise these NCD nurses? Is it through the phone? Is it on a weekly basis? Or how does it work? Thank you.
Yeah, you're right. We have not yet made headway in kind of adding the salary. Those are discussions that are ongoing with our minister. And one of the things that is my day-to-day job is just pushing for that. And I agree with you completely. At the moment, it's not there. But at least I think the sense of prestige and the autonomy that the nurses get working, there has been somewhat, to some extent, a motivator and the knowledge that they get. But I agree completely with you. In terms of asking, what was your other question? It's gone off my head. The lights. I forget what you asked, sorry.
How do the doctors supervise?
Oh yes, the doctors come physically. Oh yes. The doctors come physically. It's quarterly that they do come and just make sure. Of course, we interact with them when we consult with them for cases, but they do come every 3 months. And so it's a physical visit because we're in the rural areas, and they do come. Thank you.
Yeah, the turnover is a huge barrier for all of our settings. And then expecting community workers to work for free, no? It's also a huge challenge. So as this session is coming to an end, I want to give each of you a final opportunity to give your final reflections on this, whatever you want to highlight about how we can best integrate care services for the benefit of our patients in your different settings. whoever wants to start.
I've talked a lot, let me continue. No, mine is very quick. It's just to say I think integration is great, and in our systems it's a good thing, but I think Africa, we just need to move away from the medical model. We really just need to move away from it and begin to look at it from a biopsychosocial, whatever new term they coin every other day, model that's really looking at the patient holistically and make every effort to focus on prevention rather than cure. And if we can move our system into that level, then I'm hoping the next panel that sits here is not talking about, is talking about integration, but perhaps integration of health rather than illness, of care rather than cure, of, what can I say, episodic fragmentation into rather into individualistic care, into maybe family care, community care, population health, and bringing the resources, the knowledge, the skills that are in all of us to shift that into that level. If we can do that, I think it would be great. But thank you so much for your questions, for engaging, for listening.
Yeah, I would really like to add on and say that in the context of integrated health services that have differentials in them, coverage is not enough, okay? In the context of HPV, it's not enough to say you've received a vaccine. It's, have you received protective levels of this vaccine? So as we talk about integration, we should also be able to have case in points for services that need distinction and where we need to approach it in a manner where effectiveness is not just coverage, but the quality of service that is offered to ensure protection. Thank you.
Yeah, what I just like one word, collaboration. Because like the project we do in Cameroon, it takes a lot of collaboration with other health systems, with the government, because we are faith-based. But sometimes we see that in Africa, this collaboration is difficult to come by because people want to compete with each other. Sometimes you are the first to come up with a project. The other sector is seeing you like you are coming to challenge all of us. But meanwhile, you just need to collaborate. Sometimes you see two hospitals in the same town, big hospitals, and they are competing against each other instead to collaborate. So I think if we collaborate, we'll go further than if we start competing with each other. Thank you.
I'll echo that and also what the other panelists have said and say that integration is the way of the future. We have to break the silos in provision of care. We cannot remain with vertical programs. The mental health program, the PMTCT program, the MCH program, they all need to see that they are looking after one patient and therefore need for holistic care. Thank you.
Thank you all. We have come to our time. Thank you for so much engagement. And